We're going to take questions from the floor. I think there should be microphones around. If not, if you shout, and I will repeat the questions if we've not heard them. While you're thinking of questions, I'm just going to ask a question to James and Joe. What you've described is great, and yeah, it's something that we in Nottingham, for example, have been striving to do. One of the challenges for us comes back to sustainability and how we make these things cost effective. There's no doubt if you're reducing complications, they should work out cost effectiveness. But do you have data to support that? Are these things that you've done, like the COPES clinic, like your perioperative medicine model, are they cost effective?
So what we've found is we got an initial grant from the Health Foundation. That kind of like started the project. After that, after the year was up, we essentially then needed to go to our department, go to the finance director, put a business case in to essentially make it sustainable. They looked at all the numbers. Our length of stay had decreased. Our complication rates had decreased. And on the background of that, they have basically funded 4 PAs plus perioperative nurse specialists to work with us for that.
And I think the thing we said about keeping data and auditing the practice is really important. And now we're coming to a year of having our COPES clinic. It's going to be exactly the same. It's going to be a question of looking at the data that we've collected and demonstrating that those patients have a...
And this is really where the PQIP data really fits into that, I think. Being able to access this sort of high-quality data that we've been talking about gives us the ability to go to the business managers, to go to the finance directors. Any questions from the floor? Don't be shy. At the front.
There's a microphone coming.
Thank you. I really enjoyed all the talks. Quite a question for Joe, if that's okay. Because we've been looking for some time to try and streamline our Preop Assessment clinic from Arrow Park on the Wirral. And it's just sort of the practicalities, really. So you have a band 6 triaging all the Preop Assessment forms, and then, so are they coming straight from the surgical clinic?
So they come straight from the surgical clinic. They get seen by the nurse who's in the initial Preoperative Assessment clinic. They get triaged to red, amber and green. And then our admin lady, who compiles the spreadsheet as well, then sends them back to the bookings for whichever specialty it is, and they then will know, if they're green, they know that they're able to book them straight for onto a list. And if not, they know that they need to book them. So it will vary hospital by hospital, and I know that even Ipswich, who's part of our trust, have a slightly different system. So, but for us, they go back to the booking clerks to book them into the appropriate pre-assessment.
So then would that be another appointment for the pre-op assessment, nurse-led?
So if they're amber, they get a nurse-led pre-op assessment. If they're red, they will get another...
So sorry, that amber to the nurse-led, is that on... Do they automatically have that on the same day, or would they come back?
No, not on the same day. They'll come back for that. But for those patients, we see the initial preoperative assessment as an opportunity to try and identify those problems, which, particularly things like the joint replacements, who might wait a couple of months for their nurse-led pre-op assessment. Yeah. If we know at that stage that their diabetes is not well controlled, or their blood pressure is not well controlled, or they're anemic or whatever, we can be then getting on with sorting that out, rather than, and I'm sure we've all seen it, that they come to their long nurse-led pre-op assessment the week before their surgery. It turns out that they're anemic, and then the poor patient who's been waiting 2 months, where they could have been doing something about it, they then get delayed. Okay,
and then another practical question, sorry, because we've been trying to sort this out for ages. What do you do when she's on holiday? That seems
she works. She works in the team, so there are about 4 of them.
All the same banding? Or?
The other 3 are band 5, but she's in charge of them. And they usually, in the clinic, have an HCA working with them who does all the blood pressures and swabs and stuff.
Okay, all right, thank you.
So there's a question right at the back, and while the microphone's just going back there, we've got some questions on the screen here. So, James, so what do you guys do in York about patients with high HbA1cs awaiting cancer surgery?
So, for purely elective procedures, anyone with HbA1c more than 69, they will be postponed. They will go back to their GP, or if it's a complex patient, they will go to their diabetologists. For cancer surgery, we would continue with the surgery itself. We would let the diabetologists be aware that the patient was coming in. The diabetic nurses would possibly see them beforehand, but more likely would see them after the surgery, purely just because of the time frame.
And I think that's really critical to remembering that the priority in the PQIP targets is around measuring HbA1c, not saying that every patient who's coming for surgery in the PQIP program has to have an HbA1c of less than 69, because one does have to compromise due to the urgency of the surgery. But if you don't measure it, then you don't know where you are to start with. You can't start that collaborative pathway off, and those patients may end up not having the best perioperative care.
Okay. Any further questions? There's a hand right up there. Yeah.
Yeah. Just a question for James. Thanks a lot. Did I get it right that you do send the patients back to the ward with arterial lines, and the nurses are happy to manage them on the ward and give vasopressors as well?
So we've got an area of our colorectal wards which we call it a nurse enhanced unit. Essentially, it's a level 1 unit with monitors. We treat it with one nurse to 4 patients, so it's not quite high dependency. It's also not quite the ward. But yes, so a lot of the work we did was based around the safety of having arterial lines on or outside of critical care. And that's where our perioperative nursing team, they were the ones that trained the nurses up to be able to look after arterial lines safely on the ward. And certainly up to now, we've had no critical incidents related to arterial lines. We've had no complaints from the nurses. And to be honest, the nurses really enjoy looking after these patients. The feedback that we get from them, because it's something a bit different. And in terms of the vasopressors, if the vasopressors are increasing, they will then be referred on to outreach and high dependency, and it will be a fast track referral down to high dependency, so that you're not having patients on escalating levels of inotropes.
No, that is fantastic, because I mean, I do understand the point, but in the current climate of limited number of nurses and things like that, that is quite a good service that you guys are providing. That's great. Thank you.
Any more questions? There's just a couple. Just while the microphone's getting there. So, Chris, so how do you guys deal with this two-tier system that exists with enhanced recovery in terms of people who are English speakers, and presumably you have quite a big population that are not?
It's a difficult one. I mean, I'll be honest, in Guildford we don't have that many non-English speakers, but we do have them. I think the real key is to get them early. I think with any good enhanced recovery program, it's getting the pre-assessment, the pre-op education, the counselling. If you get that right, patients generally do what they're told. And if you get the message right at the very, very beginning, and that can be through family members. I find that wives are particularly useful at bullying their husbands and what have you. So if you get them on side very early, then it helps.
And I suppose just a statement question, are you guys going to get rid of the term enhanced recovery? Surely this is just recovery now for you guys.
It is. Probably we should, yeah.
Yeah. Just the back.
Thank you very much. I have just got 2 questions for Joe, please. Number one is, like, when you triage those patients on the checklist, which are red, green, and amber, is that something that the surgical colleagues can do it in their, clinics? Why do they need to come to a separate clinic, from the nursing point of view, and what do they do differently? And the second one is, when you have triaged them as amber or red, what do you do? Do you do any measures in the hospital, or do you refer them back to the GPs? How do they correct those things, which you have highlighted, please?
So you're right, the surgeons can do it, but obviously the time is limited in their clinic. But what we do say is that if you think this is a really high-risk patient that you want input in, you can tick red straight away and refer them to the COPES clinic or anything you like. And we really encourage our surgical colleagues to do that. And actually, they're getting the hang of it pretty well now, some specialties more than others. So that works pretty well. And what was the second part of the question? What do we...
Second is, like, if you have just highlighted some of the patients as amber or red, so how do you actually correct those things which you have highlighted that they need correction?
So it depends.
Do you do it in hospital, or do you send them back to the GP?
It depends what the problem is, and we have different pathways for each thing. So anemia, we have an anemia pathway. That will depend on the urgency of their surgery. So the less joint replacements, for example, will go back to their GP for a trial of if they're iron deficient, a month for oral iron. So we have a pathway for anemia. For blood pressure, we have a standardised letter that goes to the GP, so the patients go to their GP for management of blood pressure. So it depends. We actually only, for the patients with lots of comorbidities, there are only a few things that we look for, particularly in that clinic. So it's anemia, poorly controlled diabetes, poorly controlled blood pressure, poorly controlled thyroid disease, and the BMI thing. And all of those have a standard procedure for how they will be managed.
Thank you.
Any more questions from the audience? Just while you're thinking, so there's a specific question for James about what actual specific vasopressors do you use?
So we've kept it very simple on the wards. We use metronidazole, and we run it at 0 to 6 mils an hour. If it's getting to the stage where you're at the top end of that, that's when you'll get a referral down to critical care. So yeah, so it's low dose vasopressors, and a lot of the time it's there to counteract the effects of any epidurals they've got in, rather than we're not giving huge doses of inotropes or pressors for these patients.
So there's an interesting question there at the top, and I'm just going to do a straw poll of the audience. So how many intensivists are in the room? Okay, and so I know there's a bit of crossover, I don't fully understand this, but how many anaesthetists? So lots of anaesthetists. I dread to ask this question, how many surgeons? Oh, there are a few, good. And how many nurses? Oh, so there's probably about 20, 30 nurses in there. Surgeons, can I ask my anaesthetic colleagues in the audience next year, can you grab one of the surgeons by the scruff of their neck and bring them down to hear these talks? Because it's really, really, really important that they hear what's actually going on with their patients, because ultimately I end up in the coroner's court when one of these patients goes wrong. So it's really important for them to be here. Any other questions from the audience? At the front.
Well, next year, should we bring the senior surgeons or the junior surgeons?
I think you should bring all of them. Yeah. But that's a really good point. I mean, you know, you could make an argument that surgeons who are towards the end of their career actually have less investment, but actually they have the most knowledge. For example, I'm one of the youngest surgeons in my department, but I'm head of department because I have the most. I have the most to gain from the decisions I make at the moment and how the shape of the department is. So I think both should come. Other questions from the audience? I have a question for Chris. So, I mean, from an upper GI point of view, when we looked at enhanced recovery or just recovery after surgery programs, we looked at Guildford because they've been doing it for a while. They've got great experience. But how do you get buy-in? How do you make sure that this turns into practice for every single patient? How do you make sure that you get buy-in from everybody in the team?
It's about reinforcement, really, and it's doing it over a long period of time. It's having the initial buy-in from, so something like OG, we got buy-in from all our OG surgeons. We did a sort of, a sort of Delphi process with the anaesthetist, the intensivist, and the surgeons, all the sort of key players. So you get buy-in from the start, and they agree a protocol, and then it's just about reinforcing it. The other key, which I should mention, particularly after the last comment, actually we have a lot of clinical nurse specialists for lots of different specialities, and they are the real drivers of this. Yes, okay, I'm standing up here sort of highlighting some of our results, but they are the absolute key. They are the ones that are pushing it day in, day out. We get regular sort of throughput of junior surgeons, junior anaesthetists that may or may not have an appreciation of enhanced recovery, but they are the ones that are there on the coalface every day, really pushing it. So they're the ones that deserve all the success.
Any other comments from the floor? There's a couple of questions here. Yeah, at the front here.
You actually forgot to ask if there are any patients here. But the question is, have any of you had formal or informal feedback from patients as to what they think about this?
Sorry. Yeah.
So with our COPES clinic, for the first 50 patients, we did get feedback from them, yes, because we felt that because it was such a small group of patients that we were seeing, of all the patients we saw across the board, it was going to be very difficult to get that kind of data that we were talking about earlier as to whether it was a changing length of stay. But one of the key things to know is whether the patients feel that this is a useful service. And the feedback was very positive. I can present that at another time. But yes, I think it's incredibly important. Yeah, absolutely.
And we do too, actually, particularly urology, which is one of my other keys. That we've had these sort of surgery schools, and now actually some of the older patients are now mentoring the younger ones coming through. So yeah, they're very positive.
So there's a question here about managing anxiety levels at admission. So do you guys do anything in York for that, or in any of the other places?
Not specifically at the time of admission. We will see all our colorectal patients in an anaesthetic or consultant-led clinic where we spend 45 minutes with the patients. We do CPET with them. We do a whole host of pre-assessment tests. Things like looking at cognition, smoking, alcohol, respiratory function. And at that point, we go through the anaesthetics and we talk to them so that they've got a period of time before coming in on the day of surgery when if they decide they want to ask something else, they can get back in touch. But specifically on the day of surgery, they essentially come into our pre-assessment ward and the nurses get them ready.
So, okay, so how do you get an orthopaedic surgeon on board in terms of optimising anemia? Exclude them from the process?
So it's just really important to engage, isn't it, with each specialty? And actually we're about to go through that, having gone through that process when we initially started the changes that we made. We're a year in now, so we're going to start it again because some specialties have engaged more than others. But you're right that some can be more challenging.
And I think this question is again for you, Joe, actually. How do you manage the peaks and troughs in terms of arrival?
It's really challenging. It just seems to have been quite lucky that the number of surgeries booked in from our main outpatients seems to be about right for a nurse and an HCA. There is because we have a centralised service, it means that all our pre-assessment nurses are in the same place. So our sister, who's the lead for that, is really quite good at, using nurses who have perhaps got some admin time to go and support the nurse who's in IPA if there is a problem, if the nurse is suddenly completely swamped. So she's really good at managing that, and I think that's really, really important. So buying from the nurses who are even more senior than the person leading the IPA service. We did try to put a clinic over in our other building that does the other specialties, but because there weren't enough patients coming through, it wasn't an efficient use of their time. So yeah, it's a challenge.
Okay. So this is going to be the final question. Psychological elements of pre-assessment. Just as a plug, my wife's being interviewed by Matt Haig just down the road later on this afternoon, where I'm going to go this afternoon to see her. But is there any psychological elements of pre-assessment that you guys do routinely?
We don't really cover the psychological element, to be honest. We talk to them, but we don't have any way to refer them to if there was issues.
We do a little bit for the urology, I must admit. We've got a psychosexual physician who is involved in that, and there's a lot of preoperative counselling, particularly for the having the ileostomies and what have you. So yes, in that, but not really.
I think the patients who are high risk, who go through the clinics where they spend a bit more time, do get a little bit, because they have a bit more time to ask questions and get a bit of support, but we don't have any formal psychological.
Okay.
I think we will have some discussion, probably during the panel discussion and later on today, about the place of things like surgery schools and rehabilitation programs. And I think everybody focuses on the exercise aspect of prehab, but actually the psychological preparation bit of it is critically important as well. So hopefully that'll come out later today.
Okay, so I'm going to bring this first session to an end. I would like to thank all our speakers and thanks to you guys for all the questions. And if we can come back at 22 for the start of the next session. Thank you.